Ladies and gentlemen, thank you for standing by. Welcome to the CDC Perinatal Quality Collaborative Webinar Series. During the presentation, all participants will be in a listen-only mode. Afterwards, we will conduct a question-and-answer session. At that time, if you have a question, please press the star followed by the 1 on your telephone. You may also enter questions at any time throughout the webinar by using the chat feature located in the lower left corner of your screen. If you need to reach an operator at any time, please press star 0. As a reminder, this conference is being recorded February 17, 2017. I would now like to turn the conference over to Dr. Shakiba Henderson. Please go ahead.
Good afternoon. My name is Shakiba Henderson, and I'm an obstetrician gynecologist and medical officer in the Division of Reproductive Health here at CDC. I currently lead our division's activities in support of state-based perinatal quality collaboratives, which provides support to 6 state perinatal quality collaboratives in California, Illinois, Massachusetts, North Carolina, New York, and Ohio. And we also provide resources for state PQCs across the country, including the newly launched National Network of Perinatal Quality Collaboratives. I would like to welcome you to today's presentation for the CDC Perinatal Quality Collaboratives webinar series. Today's webcast will be an informative presentation of current strategies to improve antibiotic use in newborns. Improving antibiotic use is an important patient safety and public health issue. Improving antibiotic use is an important patient safety and public health issue, as well as a national priority. This webinar will provide an overview of CDC-supported state-based activities to prevent healthcare-associated infections, discuss improving antibiotic use in newborn patients, and present the Perinatal Quality Collaborative of North Carolina's Antibiotic Stewardship efforts. At the end of this presentation, you will have the opportunity to ask questions and participate in a discussion with the presenters. As previously mentioned, you may also submit questions via the ReadyTalk chat function throughout the presentation. A recording of this webinar will be archived on our webpage at www.cdc.gov/reproductive health/maternal infant health/PQC. Handouts were made available with the reminder email sent to all registrants today and are attached under downloadable files in that email. Handouts will also be made available again to registrants in a follow-up communication after the webinar. I will be our first speaker for this afternoon and will first give a brief introductory overview of Perinatal Quality Collaboratives. Our next presenter will then be Elizabeth Mothership, who serves as the lead for strategy and integration of state-based healthcare-associated infection and antibiotic resistance activities in the Division of Healthcare Quality Promotion here at CDC. Since 2011, Ms. Mothership has worked on policies and partnerships in support of their mission to promote safety, quality, and value in healthcare delivery systems. She is focused on partnership building and working with state health agencies to promote best practices of healthcare-associated infection policy implementation for building sustainable healthcare-acquired infection programs for prevention impact. The next presenter will then be Dr. Arjun Sreenivasan, who is the Associate Director for Healthcare-Associated Infection Prevention Programs in the Division of Healthcare Quality Promotion at CDC. Dr. Sreenivasan is also a captain in the U.S. Public Health Service. He's an infectious disease specialist and oversees several CDC programs aimed at eliminating healthcare-associated infections and improving antibiotic use. Before coming to the CDC, he was an assistant professor of medicine in the Infectious Diseases Division at the Johns Hopkins School of Medicine, where he was the founding director of the Johns Hopkins Antibiotic Management Program and the associate hospital epidemiologist. He currently serves as expert faculty for the Vermont-Oxford Network Choosing Antibiotics Wisely iNICU Collaborative, which is working to reduce overuse and misuse of antibiotics in neonatal intensive care units. His presentation will then be followed by our final presenter, Dr. Marty McCaffrey. Dr. McCaffrey is a neonatologist and professor of pediatrics in the Division of Neonatal and Perinatal Medicine at the University of North Carolina, Chapel Hill. He is a retired captain from the U.S. Navy Medical Corps, and after 20 years of service, where he served as the director of the neonatal intensive care at the Naval Medical Center in San Diego and as the Navy Surgeon General Specialty Leader for Neonatology. He is a member of the National Perinatal Information Center Board of Directors and is the director of the North Carolina Perinatal Quality Collaborative, whose mission is to make North Carolina the best place to give birth and be born. So I want to start by giving a brief overview of state-based perinatal quality collaboratives. State Perinatal Quality Collaboratives, or PQCs, are networks of perinatal care providers and public health practitioners working to improve pregnancy outcomes by advancing evidence-informed clinical practices through continuous quality improvement. PQC members identify care processes that need to be improved and use the best available methods to make changes and improve outcomes as quickly as possible. State PQCs include key leaders in private, public, and academic healthcare settings with expertise in evidence-based obstetric and neonatal care and quality improvement. The methodology that PQCs use is based on quality improvement principles developed and used in other disciplines and specialties, and is dependent on baseline and ongoing collection of data and rapid return of data to member facilities to meet objectives to improve care. PQC strategies include use of the collaborative learning model, use of rapid response data for quality improvement, and providing quality improvement science support and assistance to hospital teams. The ultimate goal of PQCs is to achieve improvements in population-level outcomes in maternal and infant health. Although individual institutions and organizations have been able to achieve improvements in perinatal care, regional PQCs serve a unique role because they encourage taking on the responsibility of improving outcomes for the entire population of the region's mothers and infants. They also understand the regional network of perinatal care and collaborate among teams from both the hospital and community. And in addition, they are able to compare performance among hospitals that are operating within a similar demographic, economic, and health services context. Members of a regional quality improvement initiative represent a community of change, and this model has been shown to be successful for rapid dissemination of evidence-based protocols and processes. As you can see by this map, the number of state-based PQCs has grown considerably over the past decade, with an active PQC now in various stages of development in almost every state. The main goals of CDC-supported perinatal quality collaboratives is to provide support for funded states to expand current efforts within the state and to use the experiences and knowledge gained from these successful CDC-funded PQCs to help other states, which included the development of a resource guide to provide assistance to states that may wish to form PQCs or that are facing challenges with PQC development. This support also included support for the formation of a national network of PQCs across the country. CDC, in collaboration with March of Dimes, has supported the development of the National Network of State Perinatal Quality Collaboratives, which is a consultative and mentoring resource to increase capacity in states to improve maternal and infant health. The mission of the network is to support the development and enhance the ability of state perinatal quality collaboratives to make measurable improvements in statewide maternal and infant health care and health outcomes. The network was officially launched in November of 2016 with the goals to strengthen existing purchasing leadership, identify and disseminate best practices for establishing and sustaining PQCs, and to identify and develop tools, training, and resources necessary to foster the sharing of best practices to support a sustainable PQC infrastructure with data-driven quality improvement processes to improve maternal and infant health across the country. All of the state PQCs in the country came together during the network launch in November, and each state PQC presented a poster with their current projects on display. I wanted to highlight some of the state PQCs that are actively working to improve antibiotic use for newborns in Colorado, Tennessee, Oklahoma, Wisconsin, and North Carolina, which you will hear more about later in the presentation. It is our hope that the experiences and successes gained by these PQCs in this work will provide examples that can be shared with other states. Finally, I would like to draw your attention to our webpage, which contains resources for PQCs, including the archived presentations from this PQC webinar series, PQC success stories, and the PQC resource guide, in addition to a link to state-based healthcare-associated infection prevention activities. We encourage you to check this page for additional information about PQCs, including contact information for PQCs in your state. I would now like to turn the presentation over to Elizabeth Mothership.
Thank you, Shakiba. I'd really like to give a special thanks to the Division of Reproductive Health for inviting us to present on this joint webinar. The goal of presenting together is to connect the state and local healthcare-associated infection and antibiotic resistance programs currently working on infection prevention and antibiotic stewardship efforts with the Perinatal Quality Collaboratives and other existing resources in order to maximize efforts. In some states, the HAI programs and the PQCs are already connected, as you've heard, through their work previously on CLABSI prevention. We think there's a great opportunity to expand the collaboration between state-based healthcare-associated infection and antibiotic resistance programs and PQCs in the area of antibiotic stewardship as well, and to encourage connections between the HAI-AR programs and PQCs who may not already be working together. So first, I want to give a brief introduction to our division, the Division of Healthcare Quality Promotion. DHQP priorities have not changed, but we know there is a need to do more to protect patients. We continue to work to prevent healthcare-associated infections, including those caused by antibiotic-resistant pathogens, and are working to eliminate device and procedure-related infections like central line-associated bloodstream infections and catheter-associated urinary infections and surgical site infections from all healthcare settings. We are working to reduce transmission of infections between patients, infections like Clostridium difficile, the carbapenem-resistant Enterobacteriaceae, and MRSA through approaches like improving environmental cleaning and understanding how patients move between facilities. We are keenly focused on working on better ways to detect and contain new types of resistant pathogens and to control outbreaks of all healthcare-associated infections. And we're also focused on improving antibiotic use in every situation. For many years, CDC has been a leader for providing education and training about antibiotic stewardship through the Get Smart campaign. More recently, even greater emphasis has been placed on improving antibiotic use across all areas of healthcare and in the community as a result of CDC sounding the alarm about antibiotic resistance. There is no doubt that overprescribing and misprescribing is contributing to the growing challenges posed by Clostridium difficile and antibiotic-resistant bacteria. And studies show that improving prescribing practices in hospitals can not only help reduce rates of these infections, but can also improve individual patient outcomes and reduce healthcare costs. But of course, we don't do this work alone. DHQP works in close collaboration with many partners, both within CDC and externally, for implementing proven strategies for improving antibiotic use in all healthcare settings, and for developing new and improved strategies for special populations and rural hospitals. We work closely with state and local health departments and the Emerging Infections Program as a core public health prevention network. And we collaborate with academic centers through the Prevention Epicenters to conduct innovative infection control and prevention research. We also work closely with our federal partners like CMS and others, with our public health and healthcare partners at both the national and local levels on practices and policies, including payment policies that promote appropriate antibiotic use. And we seek ongoing input from patients and patient representatives who bring a critical perspective and reinforce that our purpose and our mission is to protect patients and save lives. Last year, because of the budget initiative CDC received for combating antibiotic resistance, we were able to significantly increase support to the state and local HAI-AR programs. HAI-AR prevention programs work at the local level with many of the partners mentioned on the previous slide in order to implement these prevention strategies and to improve antibiotic prescribing across all healthcare settings and in the community. In all 50 state health departments and 6 local health departments, we've expanded core capacity to prevent HAIs, respond to outbreaks, and contain antibiotic resistance threats, including adding funding for enhanced laboratory capacity for carbapenem-resistant Enterobacteriaceae testing. And in 28 health departments, that's 25 states and 3 major cities, programs are working as prevention networks across public health, healthcare, and the community to prevent transmission of Clostridium difficile infections and AR pathogens, and to measure and improve antibiotic use in acute care hospitals, such as through reporting to the National Healthcare Safety Network. It's really undeniable that partnership is critical to making a difference in preventing infections, protecting patients, and improving antibiotic use. In addition to working with the Perinatal Quality Collaboratives, some states have joined the effort of the Vermont-Oxford Network, as you've heard, the Quality Collaborative called Choosing Antibiotics Wisely, which focuses specifically on key components of antibiotic stewardship programs within NICUs. The Division of Healthcare Quality Promotion has partnered with the Vermont-Oxford Network, and we're proud to have 2 of our experts, Dr. Arjun Sreenivasan and Dr. Dan Pollock, working as faculty for this effort. There are already at least 5 statewide collaboratives working with VAUGHN. And in 2017, VAUGHN is working to build additional capacity in partnership with interested states and organizations who will help lead and scale up local and regional antibiotic use improvement efforts. So this can be another great opportunity for the state HAI-AR programs and can add to collaboration with the Perinatal Quality Collaboratives as well. So that's it for me. I'll now turn it over to Dr. Arjun Sreenivasan, who will talk in more detail about improving antibiotic use in newborn patients.
Great. Thanks so much, Elizabeth, and thank you to all of you for joining the call today, and as Elizabeth said, certainly to Kiba for her leadership and the leadership of the Division of Reproductive Health here at CDC for bringing us all together today. I'm going to try to convince you in the next few minutes of these fundamental facts, and I don't think my task is too challenging because I think most of you are on the call today because you already know and believe that most or all of this is true, that there is room to improve antibiotic use in our NICU and newborn settings, that improving the way we use antibiotics will have direct benefits to our patients, that there are ways that we can do this, and now there is increasingly a will to do this. We only need to find the best ways to make it happen. There have been a number of studies that have demonstrated that there is room for improvement. There are opportunities to improve antibiotic use in NICU settings, and want to highlight a couple of those for you. And the first is this. This is directly looking at antibiotic use that was thought to be unnecessary. And this was a retrospective study done in a NICU. And what they found that about a third, 35% of the neonates in this unit received at least one inappropriate course of antibiotics, mostly because of excessive continuation of antibiotics that could have been stopped earlier. Vancomycin was the most commonly misused antibiotic, with about a quarter of the days being considered to be inappropriate. And carbapenems were most frequently used inappropriately. About 43% of all of those carbapenem days were considered to be inappropriate. And certainly that is a very concerning finding, given that carbapenems are one of our kind of last resort antibiotics. We also have some very nice data that Joe Schulman and his colleagues have published demonstrating the incredible variation in the use of antibiotics in a series of number of NICUs throughout the state of California. And this is just a box and whiskers plot showing that the rates of antibiotic use ranged from almost no neonates getting antibiotics to almost all neonates getting antibiotics in these 127 NICUs. And it doesn't allow us to comment directly on whether or not all of that use was necessary, unnecessary, appropriate, inappropriate. But I think those of us familiar with quality improvement know that whenever we see a range that ranges from somewhere between almost no one and almost everyone getting something, there is clearly some room and opportunity for improvement. The overuse of antibiotics wouldn't be an issue if it didn't have direct consequences for our patients, and it certainly does. One of the big ones, of course, is the growing epidemic of antibiotic resistance. And of course, as all of you know, the newborn population, and particularly our NICUs, are not being spared this problem of antibiotic resistance. This was data, the most recent data that I can find in my literature review, showing that antibiotic resistance is indeed rising, and rising very sharply in the NICU setting. And it's not just with MRSA and gram-positive infections, but also look at ESBLs, extended spectrum beta-lactamase producing organisms, and even down at the very bottom, the beginning of the emergence of carbapenem resistance in our NICUs, making our needs to look at carbapenem use even more important. We also know that the overuse of antibiotics has some really direct clinical impacts on our neonates. Here are two nice studies that looked at that, and they looked at patients in NICUs who got extended courses of antibiotics, so more than 5 days of empiric therapy despite having sterile cultures. And the authors said in both of these studies that these were situations where the use appeared to be inappropriate, couldn't definitively say so, and look at what they saw. If you got extended courses of these empiric antibiotics despite having their sterile cultures, you were at increased risk for necrotizing enterocolitis, death, and prolonged length of stay. So some really serious clinical impacts from the potential overuse of antibiotics. And of course, we are increasingly understanding how the exposures to antibiotics greatly impact the microbiome. And we're only beginning, I think, to understand just how important the microbiome is to our health, and especially to the health of our youngest patients who will be impacted potentially for the rest of their lives by perturbations in their microbiomes. But there's already some studies showing that genetic analysis of sequential samples showing that acquisition of resistant bacteria begins at birth and can in fact be driven by systemic antibiotic therapy. And the authors of many of these studies point out this is so important not just to the infant who's getting the antibiotics, but because of the risk of transmission of infections within the neonatal setting, this antibiotic exposure and this microbiome disruption has implications for all of the patients in that intensive care unit. We know, and there's good studies to support the fact, that improving antibiotic use leads to important benefits both to our individual patients and for the larger society. And I think it's important to emphasize both of those. I think in the past we've overemphasized the societal benefits, the need to improve antibiotic use for some kind of nebulous good for society at large. And that's important and well and good, but as providers, we know that what's most important is the care of the individual patient who's in the isolette right in front of us. And it's important to emphasize that improving antibiotic use will have direct benefits for those individual patients. Improving antibiotic use can reduce antibiotic resistance. This is data from a hospital where they restricted the use of some really broad spectrum antibiotics and then looked at the susceptibilities of Pseudomonas aeruginosa before and after that restriction. And as you can see across the board, not only did the emergence of resistance slow, they actually had a reversal in resistance. The isolates in that hospital of Pseudomonas actually became more susceptible as antibiotic use began to go down. So it shows us that we can actually use improvements in antibiotic use to turn back the clock on resistance. Important to emphasize, though, that this is not just about the height of bars on an antibiogram. This has direct impact on patients. This is a study looking at patients who got either short courses of antibiotics, a 3-day course, compared to patients in an ICU. These are adult patients who got longer courses of antibiotics. And as you can see, the patients who got the shorter courses of antibiotics were significantly less likely to go on to develop an antibiotic-resistant infection during that hospitalization. And I think this does bear direct relevance to patients in our neonatal intensive care units who, of course, oftentimes have very long lengths of stay and are at very high risk for getting resistant infections during the course of that stay. So reducing the antibiotic exposure could help decrease the risk of subsequent resistant infections. And of course, in an era when patients are increasingly sick and increasingly complicated and where we have more challenges with antibiotic-resistant organisms, it only makes sense that having input from experts in antibiotic use would help improve patient outcomes. And that's indeed been shown to be the case. This was a randomized trial where patients were randomized to either get input from an antibiotic stewardship program, shown in the gray bars, or to get whatever antibiotics the providers would have normally prescribed. And as you can see, the patients who had the input from the stewardship program were almost 3 times more likely to get a guideline-recommended antibiotic, which meant that they were almost 2 times more likely to have a cure of their infection and 80% less likely to experience a treatment failure. So improving antibiotic use has a number of important benefits. But how do we make those improvements? Well, again, here we are able to turn to some specific examples from the NICU setting, showing us a variety of different ways that people have made measurable improvements in antibiotic use. The first was a focus on vancomycin. As I showed you earlier, vancomycin was one of the most commonly used antibiotics in a couple of those NICUs where it's been looked at. This was a study where there was a lot of vancomycin use, and so they implemented some guidelines. They came together and made consensus guidelines for how they would use vancomycin, and as you can see, the number of patients who were started on vancomycin dropped, and the number of starts decreased as well, so significant reductions in vancomycin use. Another NICU took that same idea and said, well, let's not just apply this to vancomycin, let's look at all of our broad-spectrum antibiotic use. And in fact, when they looked at broad-spectrum antibiotic use, they had seen a sharp increase in that use. They, again, got their experts together, developed consensus guidelines, an agreement for how they were going to use these broad-spectrum antibiotics in their NICU, and you can see that the use of these targeted broad-spectrum antibiotics dropped by 61%, and total antibiotic use in that NICU dropped by 18%. Through a lot of the work that you've heard a little bit about from Elizabeth that's been going on through the Vermont-Oxford Network's iNICU collaborative on antibiotic use, we've seen a tremendous focus on early onset sepsis. A lot of folks are fundamentally revisiting the management of this condition and beginning to ask this question: does every neonate with potential signs and symptoms of sepsis need the same approach? It's one that we had taken historically, and I think it's to their credit that they're beginning to revisit and challenge that assumption that we needed to do this the same way in every situation. A number of hospitals, NICUs in this collaborative, have been implementing a variety of different measures, some new risk assessments, and changing the way that they approach neonatal sepsis. And the results have been really encouraging: drops in antibiotic exposure and even reductions in hospitalizations, allowing newborns to stay at home with their families rather than being in the hospital. Some really exciting results there. This is a really critical time for improving the way we use antibiotics for antibiotic stewardship in the NICU setting. Certainly, we are confronted by the threat of antibiotic resistance, and we do feel like we are at a critical point in trying to get on top of this problem before it becomes even more significant. And antibiotic stewardship is now a requirement for all hospitals that are accredited by the Joint Commission, which probably applies to most of the hospitals that have neonatal intensive care units. And so there is now a requirement that hospitals, including the NICUs, take steps to improve the way they use antibiotics. So the question, I think, is not whether we should do this, but how we do it. And we're seeking to answer some really important questions. First of all, how do we implement effective antibiotic stewardship in NICUs? There is a lot of published literature looking at this in adult and even in pediatric populations, but less in the NICU. So we need to figure that out in the NICU setting. We know that it's going to look different from hospital to hospital, and we think in every hospital it can be a partnership between the experts in neonatology and the NICU staff, the NICU nurses, and the antibiotic stewardship team. We're also considering how we best monitor antibiotic use in NICUs to provide data for action. CDC, as you have heard, is partnering with the Vermont-Oxford Network on this iNICU collaborative, and our goal really is to find the ways to implement opportunities to improve antibiotic use for all newborns. And the collaborative is also providing us an opportunity to answer that second question: what data on antibiotic use and resistance, frankly, is going to really drive the important actions in our newborn population? As Elizabeth mentioned, there are several states that are now all in, and I think Madge has even chatted that we've got a couple of other states, Georgia and West Virginia, that have come on board with all of their NICUs, and that's obviously been very exciting. We think that in many states there have been some really nice opportunities for collaborations between the state healthcare-associated infection prevention programs and the perinatal community, and we are having this webinar to answer this important question: are there more opportunities to connect these groups to advance the care of newborns? I'm going to close by saying that we know from our experience in healthcare-associated infections, and you all know from your experience in perinatal quality collaboratives, that these state-based efforts can be incredibly effective in improving care. And we would like now to harness the power of these state collaboratives to try and improve antibiotic use in newborns. And we are eager to learn from you what we can do to help with that effort. And I'm going to conclude there and turn it over to Marty to talk a little bit about antibiotic stewardship and neonatal sepsis. Marty?
Hey, thanks so much, Arjun. And thank you all for the opportunity to speak with you. Good afternoon and good morning wherever you are. I'm not going to beat to death the data that Arjun has already well presented, but I think it's just worth reiterating a couple of pieces of information here. This again is back to the study that Arjun presented, Joe Schulman's work and the work of the folks at the CPQCC, and it's really interesting that really some of the seminal work that has been done in the area of antibiotic antibiotic stewardship in newborn and NICU care has been done by the Perinatal Quality Collaboratives, and with CPQCC leading the way in this. What I want to call your attention to is the graph on the right-hand side, which shows the variation in antibiotic use rates that you find in different types of NICU, so similar types of care, whether they be regional, intermediate, community, or non-CCS California certified NICUs. And the tremendous variation that you see there, the variation depending on the NICU type is anywhere from 7 to 41-fold in antibiotic use rates. And the outcomes are no different within those certain types of NICUs. So when the outcomes are no different and we're all doing something so differently, we can't all be right. And Arjun is right on. He's made the case well, and the data is out there, and the case has been made that we need to be doing something about our practice. The discussion to this point has really focused on the NICU, however, and I think if we do that, we miss an enormous opportunity, perhaps the biggest opportunity. Once babies get to the NICU, as we know in perinatal quality collaborative work at the state level, you've missed huge opportunities to improve care, whether it be on the maternal side or on the newborn side. And so I want to draw some attention to what's going on in newborn nurseries as well. This is work that comes from Karen Pupolo and her group in looking at what happens with antibiotic prescribing for a cohort of babies that she looked at over 2 epochs, looking specifically at different CDC guidelines, which changed in the years 2002 and then in the years 2010 in terms of what we did with babies with Group B strep. What's important to note is in the CDC 2010 epoch, where we still and currently are in an era where we're evaluating babies whose moms are diagnosed with chorioamnionitis. And what you see in this later epoch is 6.8% of asymptomatic infants are evaluated for sepsis in this facility, and 5.2% of asymptomatic newborns are treated with antibiotics. That is a huge proportion, a huge burden of antibiotics being imposed on babies who ultimately are going to have negative cultures. So the decision for us as neonatologists and as newborn care providers, and having been a general pediatrician out there sitting in a newborn nursery with a tachypnic baby, has always been, do I treat or not treat? And that is the question that Arjun poses here today, and I think it's one that we all have to confront very clearly and seriously as providers. Arjun has made the case for how serious this problem is, and we have to decide if we are in a situation where, when in doubt, it's best to treat. That's the way I was raised. If a baby looked like they had signs that might be subtle signs of infection, the risk was really that the baby might be infected, and if you did not treat them, what might happen to that child? And the thought process that I was raised with 15, 20, 25 years ago at this point, I hesitate to say, was that there was really no downside to a couple of days of Impingen or even a week of Impingen. And we know that is not the case. So Arjun has hit these, but I'm going to repeat them. Antibiotic resistance is a huge problem. Morbidity and mortality associated with extended antibiotic courses is absolutely there in terms of neck fungal sepsis, death, advanced length of stay. We know that infants treated with antibiotics now experience a decrease in the genetic diversity of their microbiome. And the problem there is not just that the organisms change, but that the signaling from the gut changes. And we know now and are just beginning to understand, we are in the infancy, barely, probably in the fetal stage, of understanding the impact of signaling from the intestine into what may happen later on, years down the road, in terms of programming development for an individual. And autoimmune disorders certainly are something that's potentially problematic and being looked at very heavily now when we go in and alter the microbiome, which may happen with even just 48 hours of antibiotics. The acquisition of resistant bacteria does begin at birth, can be driven by that systemic antibiotic therapy, and there are issues regarding separation of moms and babies when we go ahead and we decide that we will treat with antibiotics, and that may impact breastfeeding and bonding in the family. So should we just treat if we're not sure? Well, this is just recent data that came out of Pupolo's group as well, looking at what happens with sepsis evaluations across a national network of nurseries, and this was published in PEDS this month. This is looking at 81 nurseries in 33 states, typically the obstetric diagnosis of chorio is the most common factor used to identify treatment for risk for early onset sepsis. And 51 of the 79 sites in this study ultimately were using the American Academy of Pediatrics guidelines. 11 used a published sepsis risk calculator alone, which I will mention briefly in a minute here. And there was separation that occurred. And they detail what that separation actually was in some of their data. What you'll see in the middle with the red circles here is are early onset sepsis procedures conducted in a location separate from the mother's room? Yes, in 59%, in 76% of cases. If IV antibiotics are started on a well-appearing newborn, can newborn room in with mother? No, in 40% of cases. If IV antibiotics are started on well-appearing newborn and newborn cannot room in with the mother, where is the newborn cared for? NICU special care nursery in 75% of cases. So there's clearly issues related to the separation of mom and baby at this point, and with our focus on breastfeeding and the incredible benefits that we know that we get from that, this is something that we should all be considering. So as in anything with quality improvement, you can have the best protocol in the world and the best evidence in the world. But what is required is dealing with the culture war that is going on in your unit, whether it's a newborn nursery or it's a neonatal intensive care unit. And it's not necessarily that people are probiotics or antibiotics, but it is that people are worried about what will happen to a baby that they may not treat. And it's that training and that culture which has to be overcome with reasonable evidence to say that it's safe, not to necessarily default to the practices that we've taken in the past, because they potentially do cause real harm and can cause injury that we really have begun to appreciate over the last 5 to 10 to 15 years. The simple fact is the collateral damage of antibiotic overuse is huge. The only treatment that we use and prescribe in a hospital that can not only cause harm to the patient we're prescribing it for, but kill the patient in the next bed is antibiotics. And I think we have to really start understanding that and appreciating that. And I think in the past, I will say I have not been someone who's really thought much about that and appreciated that. But certainly work of the folks on the phone here and some of the research that we've presented and Arjun has spoken about have opened my eyes to what we really need to be thinking about and how we prescribe these medications. So I'll talk a little bit about what's going on with our group in North Carolina as one of the state perinatal quality collaborators trying to focus on antibiotic stewardship. What we have developed is a statewide initiative that includes not only NICUs, but newborn nursery units, mother-baby units. We are promoting collaborative teams at hospitals that include both newborn and NICU care areas. Currently, in our project that's ongoing now, just recently launched last month, we have 41 centers participating. 41 of those centers have not only newborn nurseries participating, but NICUs as well. We've also got at this point 3 states participating. Hawaii, Illinois, and Virginia have representative institutions. And we're also partnered with Italy, and we're looking forward to our site visit there. The structure of our project. This sort of is a little bit of the formula that we use for all of our quality improvement collaborative teams and initiatives that we form. But just like any good PDSA organization, we're constantly changing this. But for ASNS, we start out with an expert team. For us, this includes 54 members who are nurses, physicians, hospital ID consultants, parents, payers, Department of Public Health representatives, our Get Smart folks from the state of North Carolina, all participating in webinar calls and face-to-face meetings to develop an aim statement and action plan and identify the key measures. And those measures are both process and outcome measures. The workhorses for this work are the perinatal quality improvement teams at the hospital level. It's a requirement that we have a nurse, a doc, a family partner, and a front office administrative representative in that group. We put out pre-work, we do snapshot surveys, and we lead an action plan through the PICNIC team working with those local perinatal quality improvement teams. We partner across nursery and newborn care areas, and this has been fascinating for us to go out and do site visits at multiple institutions and bring NICU teams and newborn teams into the same room and speak with them and get them on the same page as far as antibiotic practice. We are introducing different elements for the different practices in those units and the different patient populations, but what we feel is critical in this is not only doing a superb antibiotic stewardship project, but also promoting collaboration and the development of quality capacity for these facilities down the road to participate with their state perinatal quality collaboratives in future work. And facilitating all of this is the PICNIC core team, which what I'm describing here is similar to what you will find in most of the state perinatal quality collaboratives who are on the line here, who certainly are working within CDC and who are now the growing members of the National Network of Perinatal Quality Collaboratives. But there's a core team that basically facilitates the work of teams in the field. What we at PICNIC do and see as our duty is to build web-based reporting systems for all of our initiatives, including ASNS. For ASNS, we have emails, calls, and site visits to recruit participating facilities. We weekly contact and facilitate the PQITs, the Perinatal Quality Improvement Teams. And then again, weekly email newsletters, webinars, and quarterly face-to-face learning sessions are critical structural elements for how we carry out this plan. Specifically for ASNS, what we are looking at as far as our aim, and we have to throw down a measurable objective aim that we expect to be able to demonstrate shows success for this initiative at the end of it, is that we will show a decrease of 20% in the number of patients exposed to any antibiotic and a decrease of 20% in the duration of antibiotic administration past the first 48 hours of life with a negative blood or CSF culture. So we are focusing on acute infection. We feel that to try and bite off all infection, certainly in NICUs, is a very difficult, challenging, and daunting project. We feel that the outcomes are much more measurable if we focus initially on acute infection. We have no doubt that there will be spillover from this project into antibiotic practices for the development and identification and treatment of late onset sepsis. But we are focused acutely right now on the acute process. We anticipate in future phases that this could go in several directions that might include surgical babies and surgical prophylaxis, that might include treatment of late onset sepsis and antibiotic courses, antibiotic selection as well. The current action plan, I will highlight just three elements in there that we have as far as recommendations. One includes a recommendation to consider the Kaiser Pupilo, I like to call it, sepsis calculator, the antibiotic timeout, and partnership with patients and families. The Pupilo sepsis calculator, for those of you who have not seen this, is available on the internet. Pardon me, I don't have the link on there, but if you plug in the Kaiser sepsis calculator, you will be brought to it out on the internet. What the Kaiser sepsis calculator does is do away with looking at just a straight up diagnosis of chorea, which has become very subjective and brings lots of babies into the realm of the antibiotic world. And it includes a number of factors, including what your sepsis rate is at your facility, gestational age of the baby, mom's temperature, rupture of membranes, maternal GBS status, and type of antibiotic treatment that was received intrapartum. So there are a number of continuous variables in here which really add additional power to the Pupilo calculator, because the risk certainly for maternal temperature and for gestational age really, depending on the continuation of the variable, heightens your risk for infection. And this is picked up by the calculator. This is conducted and calculated as far as a number of sepsis risk score that then is correlated with the clinical exam of the baby. So no one is saying that you can just plug in a number and go ahead and figure out whether or not a baby should be treated, what the temperature was, what the gestation was, etc. You have to correlate this with a clinical exam. And to sit and talk in a whole lot of detail about the calculator will require a little bit more time. We can certainly handle some of that in the question and answer period. But this is something that we're recommending for folks, and it's something that's been used in several of our sites in North Carolina. The sepsis calculator in action I can show you here, and this is from the work done by our general pediatric group here at UNC. The neonatologists had nothing to do with this. This is Carl Seashore and his incredible band of pediatric nurse practitioners putting this to work, and several other centers now in North Carolina are picking this up. But what you can see is looking at our exposure to antibiotics was sitting about 7.2% of babies until the intervention was made, which is the orange arrow pointing down, which was the introduction of the Pupilo calculator. And what we see is a reduction of antibiotic exposure to 2% of newborns. So we have seen at UNC a 73% reduction overall in exposure of newborn babies to antibiotics. And we have seen no babies be missed at this point. When you look at the number needed to treat, the calculations that were done in putting together the calculator, when you're looking at babies who are well, who have a reasonable exam and are relatively low risk, but who might otherwise have been chorio, the number needed to treat for those babies would be somewhere around 1 in 9,000 to actually pick up one baby. And I don't think there are too many therapies that we undertake that are 1 in 9,000 necessarily. The other interventions that we're undertaking in this initiative and really trying to promulgate are the antibiotic timeout. So what we're trying to incorporate is culture change here. What we hope to do is on every baby who's on antibiotics every day in this initiative, people will discuss the 5 rights of antibiotic administration. Is the baby on the right drug for the right bug, with the right dose, with the right duration, with the right levels? And every day we want folks to be doing this. We don't want them doing it every other day. We don't want them doing it after 48 hours. We believe this has to become part of how we think about antibiotics, and it's only going to happen if we do it every day and make it part of our personal rounding experience. We're also partnering closely with parents in antibiotic stewardship and newborn sepsis in North Carolina. We're developed a number of educational materials that we're using with parents to prompt them with questions that they can ask their providers. We're also offering logs for parents in terms of accounting for the numbers of antibiotic doses that their babies have received. And what we're requesting that individual units be doing is that at the bedside, they actually post where babies are in their antibiotic dose, not days, but dose, and when the dosing and the course is expected to end. We're asking that on rounds that parents be included in the rounds and this be talked about on rounds with the families so that they be engaged in the process of antibiotic exposure. We feel this is a real opportunity perhaps to start off families with an understanding when their baby is young of the potential risks for antibiotics and the double-edged sword that they present. Yes, antibiotics can do wonderful things and there's certainly indications for them, but you don't hope for antibiotics every time you go to a physician. And so this maybe will get us down the road to starting to do some education in the outpatient environment where patients might have a little bit of a different view of the antibiotic world in the office setting. The potential impact of ASNS in North Carolina, 122,000 some odd births in Carolina in 2016. We've got about 70% of birth hospitals or 70% of births accounted for in our current ASNS project. That's about 85,000 infants who are potentially going to be impacted by this project. With the hospitals that are participating. And if you use a reasonable estimate is about 7.5% of infants, newborn infants, are currently being exposed to antibiotics. That's about 6,442 babies. If we look at what we've seen with the experience published with the Pupilo calculator as well as with the experience from a couple of our sites including UNC in Picnic, we expect that we can avoid antibiotic exposure for 1,288 babies. Looking at that 20% mark, we think it's actually going to be much higher based on the UNC experience, and it may be as many as 3,000 babies a year in North Carolina who will avoid 48 hours of antibiotic exposure in the newborn nursery. So state PQCs and antibiotic stewardship are a unique opportunity, and bad on us if we miss it. The NICU is important. That's where I live. But we're missing a great opportunity on the newborn side, and we need to engage this. The organizations that have led the way with this have been PQCs, and the PQCs, state perinatal quality collaboratives, include multiple state partners who can support stewardship efforts. It includes payers, purchasers, Medicaid, DPH, and a host of others. And every PQC is a little bit different. They have different partners and different stakeholders that they've engaged, but all of these folks are able to engage and push on different pressure points to help produce, in a reasonable manner, some good end results. And that is one of the real powerful advantages of state PQCs. The PQCs doing this work are conducting the work in the continuum of care in which hospital care is provided within the state, between state nurseries and NICUs. This is a natural environment of care, and the natural go-to for a collaboration and a partnership to do this work absolutely should be the state PQCs. Stewardship also, very importantly, offers an opportunity for us to look down the road. With stewardship, there's a great opportunity to build collaboration between the well newborn side, providers, practitioners, families, administrators on those sides, with folks on the NICU side within hospitals and across the state, and that will build collaborative capacity for future projects. Future directions for PQCs for us at this point, what we've talked about, include antibiotic prophylaxis for C-sections, neonatal surgical antibiotic prophylaxis, and the treatment of later onset sepsis, which we mentioned earlier. So PICNIC ASNS at this point includes several state and international groups. It's a unique opportunity for PQCs to engage providers. Our project has an aim statement, action plan, and data reporting system that's built. The advantage for most of the state PQC projects, and certainly for PICNIC's ASNS project, is there's no fee for participation, and that is extremely limiting for a number of state PQCs and facilities. Maintenance of certification is available free of charge to participants in these efforts. And we would welcome the opportunity to partner with other state PQC leaders or any other hospitals. It's once the system is built, the systems that we build are able to accommodate multiple other participants once the initial work is done. And I've just put some contacts up there for folks if they're interested in considering joining us in the North Carolina project. I think it's important that state PQCs and now the National Network of Perinatal Quality Collaboratives really think broadly in terms of the national work that we can be doing. We have an example of this. We did this back in the early 2010, 2011 into 2012 period when we ran a project called NCAPC. NCAPC was a partnership between AHRQ, AHA, and HRET. PICNIC led that, but we were 9 states that were in partnership, 9 state perinatal quality collaboratives. We had over 100 NICUs that were engaged in that project. We had state PQC leaders who led those projects within their states. Then the action plans and measures were adopted to those states and they were executed within the states. We developed strong partnerships with the state hospital associations. We incorporated CUSP, comprehensive unit safety training, into those programs through the hospital associations. We saw an overall reduction of 48% in CLABSI rates in that project with 9 states. And the other critical element is that money and funding that came to that project went to state PQCs. What folks need to realize, and I hope the CDC will realize, they've made a big investment in the state PQC project. The opportunity with the newborn and NICU antibiotic stewardship work is to help support state PQCs in a much larger respect. And what could happen, and Arjun asked, how can CDC help? My hope would be people on the infection side and the stewardship side at CDC, Antibiotic Stewardship Group, would say these are just natural collaborative partners who we can help and we can support, and not only help them and support them in doing work in antibiotic stewardship, but in the meantime build collaborative organizations at the state level that can do great work down the road. So the thought about a national project is one that we have talked about within the NNPQC, and we talked about this at our national meeting back in Texas. during the end of last year. The impact of this potential project would be huge if you're looking at newborn nurseries and the NICUs. Just some really quick numbers to think about. If you're looking nationally, the possibility exists to avoid antibiotic exposure for almost 150,000 newborns annually if there's adoption and reasonable agreement upon the Kaiser sepsis calculator. If you look at the picnic goal of a 20% reduction in antibiotic use, or even take Vaughn's 25% reduction that they've reported for their group, antibiotic days in the NICU could be avoided for 62 to 70,000 patients. And this would be a tremendous benefit. It represents a tremendous opportunity. I think that the CDC has been very serious about trying to support state perinatal quality collaboratives. We have all said as a group within the NMPQC that we want to make this nation the best place to give birth and be born. This is what we're doing in North Carolina, and I think there's a huge opportunity now for the CDC and the infectious disease folks in the Antibiotic Stewardship group to partner with state PQCs and really make this happen nationally. Thank you very much.
Thank you so much, Marty. We appreciate your presentation. At this time, we're going to open up the lines for questions. Amber?
Ladies and gentlemen, if you would like to register a question, please press the star followed by the 1 on your telephone keypad. If your question has been answered and you would like to withdraw your registration, please press the pound. One moment for your first question.
So while we're waiting for audio questions, we'll start with the questions that were sent in through the chat function. And the first question is from Barbara Clark. Has there been research into the question of how much litigation avoidance is driving physicians or providers to opt for antibiotic use in ICUs or NICUs in the United States?
Yeah, I'll take that, Kiba. This is Marty. I am not aware of a study that has looked at that, but we've had this conversation, and my strong belief is it's not necessarily litigation that drives people in this. And I may be naive in this, but I don't think so. The people that I know who are neonatologists and general pediatricians and family practitioners dealing with these babies, it isn't so much necessarily the litigation issue. It's that they truly do worry about what happens to the baby if I don't treat him and he's really sick. And you've been raised with what the potential signs of sepsis are, and the baby's tachypnic at 4 hours. My threshold is he's going to get treated. And I don't think it's so much a litigation issue at that point as it is really just a fear that you might miss something. That's my own personal opinion. Others might have others.
Okay. Any other responses to that question? If not, we'll move on to the next. Okay. The next question is from Heather Hastings. Does the evaluation of success include cost savings from reduced antibiotic use? And I'm assuming this is referring to the success described in the presentation in North Carolina.
Yeah, so we're trying to, yeah, it's a great question. We're trying to determine how we might get to that because it would be very powerful to put some meaningful numbers on this. There has been some literature put out there from the Pupilo group looking at this in terms of the cost for treatment. The numbers are fair. I mean, the cost they can demonstrate the cost savings related to antibiotic administration, pharmacy costs, nursing costs, blood drawing, all hosts of things probably that you're thinking about as you wrote that question. So there is one article out there, and I didn't put it in my slides, but we can make that available to y'all. But there hasn't been a great assessment of that, other than the only one publication I know of from Karen on the topic. And it does show cost savings, by the way, and it's reasonably significant.
Okay, thank you. And while you're talking, Marty, is another question for you from Ben Chan for Dr. McCaffrey. I'm wondering the reason for not including pharmacists on the PQITs. For antibiotic stewardship activities, pharmacists are key partners.
Yeah. So in terms of what we're absolutely requiring, this is our generic requirement for any team that we put down in a hospital for a quality improvement team. So we want at least a doc, a nurse, a family member, and a front office representative. For all of our teams, pharmacy has been critically involved in all of them, and our expert team has included, at this point, it's got 3 pharmacists on it right now. So it's a great point. Yeah, it's an oversight that I didn't put that down. But absolutely pharmacists have to be involved in this. They are going to drive this, by the way. And especially a lot of this can be driven sort of with computerized order entry and sort of the way you sort of change practice based on that, and they are key in that.
Okay. The next question from Kelsey Everson. Using the Kaiser calculator. Okay, I'm using the Kaiser calculator and it recommends not to treat. Is there a recommended observation period?
No, so there isn't a period. It will tell you if there is a baby that you don't treat, but it will pop up in there, observe, and it will tell you that. But if a baby falls out and they say no treatment, there isn't a recommendation just to fall back just because there was a diagnosis of chorioamnionitis, for instance, where you say, well, I'll just watch them for 24 or 48 hours. So the calculator directs you fairly well. And if you haven't seen it, it's worth really sitting down and looking at. I think they've done a really good job at looking at a huge amount of data. This was a calculator derived on over 600,000 babies in the Kaiser and the Brigham systems, where they looked at data, did multiple regressions to sort this out, and pulled out the continuous variables. I mean, it's something that most of us none of us will ever be able to replicate. But what is critical is your exam in conjunction with that sepsis score. And then what lights up in the box on the calculator is what at least the Pupilo calculator absolutely recommends. You could do whatever you want, obviously. And a number of the places that are picking this up in our collaborative, they're saying, yeah, we're going to recommend it, but everyone isn't going to do it. Well, I mean, as we do in quality work then, if you don't want to do it, that's fine, but we'll just track your data and see what things look like thereafter.
Okay. The next question, I believe, can go to any of the speakers. Would these programs seek to reduce the use of antibiotic use of erythromycin specifically?
This is Arjun. Marty might want to comment. I don't think that erythromycin has been a specific focus of any of the efforts, at least that I've reviewed literature on. They've focused on a lot of them on vancomycin, on broad-spectrum antibiotics, and obviously the sepsis ones tend to focus on ampicillin and gentamicin. So I'm not aware of a focus on erythromycin. Marty?
Yeah, and I'm not sure. I'm not sure if it's a question related to eye ointment or, I mean, some moms certainly preterm labor. We see a lot of azithromycin get thrown around, right, Arjun? I mean, not so much erythro. Yes, eye ointment. No, so I haven't heard any conversation. So Gwendolyn just wrote in, yes, eye ointment. I have not heard anyone really talk much about eye ointment prophylaxis. Madge is jumping in though and said she and their initiative is not counting topical erythromycin for eye prophylaxis as an antibiotic day, and certainly we're not either in North Carolina. It's an interesting thought though.
Okay, fantastic. Okay, the next question is from Unish Gupta. Is there a growing consensus that the Kaiser risk calculator is a better approach than the CDC guidelines for deciding antibiotics for well-appearing infants at risk for sepsis? Is there a plan to modify the CDC guidelines? If so, when?
Yeah, Munish, I don't sit on Committee of the Fetus and Newborn, but some of my sources there, some of who are on the line here, have hinted that that is going to be the case. I don't know when exactly that's going to happen, but people have been saying for months now that any day there's going to be a new statement coming out on how we treat early onset sepsis and evaluate for that, and certainly focus on chorio. But the word on the street from folks in the know is that there will be something coming where probably the Kaiser sepsis calculator is going to be recognized as an acceptable and reasonable practice.
Okay, thank you. And then the next question from the chat box is to Arjun. If you're willing to share the vision of the NHSN data on AU, AR in the future?
Yeah, that was from Madge. And Madge, thank you so much for all of your helpful comments and questions throughout the webinar in the chat. You know, one of the things that we have recognized in our partnership with the Vermont-Oxford Network and all of the facilities that we've been working with in the collaborative is that the current categories that we have for measuring antibiotic use don't work very well in the NICU setting. And we are now embarking on an effort to assemble some experts from the neonatal community and begin to have some discussions to try and determine, well, what are the measures of antibiotic use that are most meaningful in the NICU population? What data is going to motivate improvement actions? How do you want to look at this data? Are there individual agents that we need to pull out that are the most important? Are there combinations like ampicillin and gentamicin that we could put together and express? And so we're just really now beginning that work, but that is one of the things that we're very focused on in this upcoming year of the collaborative is building on measurement experience. And so certainly interested in hearing thoughts and ideas on that because I think it really is a very important issue. It's a nascent one for all of the work that we're doing in the antibiotic use, and certainly we have very little experience on that in the NICU and newborn setting.
Okay, can we check to see if there are any questions on the phone line?
Again, just a reminder, if you would like to register a question, please press *1.
You can also use this line if you have any particular comments for the speakers or questions.
And there are no questions at this time.
I don't know if Madge has been very active. I don't know, Madge, if there's anything you wanted to comment on specifically.
Yes. This would be a good time. Oh, she says she doesn't have
a phone line. Okay. Well, thank you for all your chats.
Yes, we appreciate your participation. So if we don't have any other questions, I'm just going to check to make sure they're not on chat.
And there are no audio questions, Dr. Henderson.
Okay. Okay. In that case, we would like to thank all of our presenters for such an informative presentation on improving antibiotic use in newborns. We'd also like to thank all of you for participating in this webinar, and we'd like to invite you to provide feedback about this presentation and the webinar series. We'll be contacting you after this webinar for your input. We hope that our webpage and this webinar series will facilitate exchange of information and promote visibility of perinatal quality improvement activities throughout the country. You may also visit our webpage at www.cdc.gov/reproductive health/maternal infant health/PQC to learn more about CDC support of perinatal quality improvement collaboratives. Again, if you would like handouts for this presentation, they were attached to your reminder email at the beginning of the presentation and will be sent again in the reminder email. Thank you again for participating and have a wonderful afternoon.